I'm Richard Swanson. I'm a retired rheumatologist, and as such, I've seen a lot of chronic pain and acute pain. I've come to realize how different they are. And Jim and I have known each other both professionally and socially. And I invited Jim in about a year ago to give a talk on chronic pain, which you people seem to have enjoyed, and requested that he come back to talk more about his toolbox, things you can do to help chronic pain. So I asked Jim if he would do it, and he said he was glad to. So I'm going to turn this over to Jim and his background, that he's a physical therapist. He's retired, but he still works part-time. He's also very much involved in the chronic pain education process, both here and around the United States. It is chronic pain is still very poorly understood by physicians. So he has a daunting job, but I trust that he's doing it very well. And I turn you over to Jim Stark.
Thank you, Richard, and thank you, Susan, for helping to set this up. I am going to just a real quick introduction. As Richard said, I am a physical therapist. I've been doing this physical therapy for 27 years now, which means I got a late start. I was almost 40 when I started. And so I've never had the, I never was looked at as the new guy, even when I got started, because I was almost 40 when I got started. But it's been an interesting career, and I retired a little over about 2.5 years ago from daily practice because I'm so passionate about this, and I wanted to be able to help more people than I could help one-on-one. And so this is what I'm trying to devote my life to at the moment. I'm going to share my screen now, I think. And let's see. That's not quite what I'm looking for. I
Maybe
gotta pause
press
it for a second.
Yeah, you can press the escape key, and don't worry, we're used to having a little, sometimes it takes a minute.
Yeah.
Go ahead and bring
Stop
up
the share. Here we go. I got that now. Yep. Got it. Okay, so now. There we go. It's not what I want. This always seems to go so much smoother when I first get started than it does later. All right. Now then, I'll try sharing the screen again. One more time.
So when you're out of that, Jim,
I know what I need to do. So I'm gonna.
Okay.
I'll
so
set
stop
it up.
talking.
Yeah.
Okay.
So what I was trying to do is do a shortcut so it would just come right to the presentation, but I can't do it that way without having my. There we go. Now you should see a variety of things, and that should do it. Oh well. You can see my screen, I assume.
Yes.
Okay, very good. We're going to get started. So I call this finding your way back home, the pain toolbox, finding your way back home, because what I think you need to do is to come back home to yourself. If you are dealing and living with chronic or persisting pain, and I use those terms interchangeably, then you've kind of lost who you were in many cases, that you don't have the kind of joy in life, purpose in life, because it hurts too much. So that's what we're going to try to work on. And it's still not doing it. Okay, I have to do it this way. All right, very good. So our objectives today, we're going to talk about definitions of pain. And I want to tried to argue that pain is more of an experience than it is a sensation, and that the conceptual models about how we understand pain are really unclear because experiences are really unclear. What is physiologically going on in your body when you experience love? You can describe it, but not well. When you see what's going on when you look at a beautiful sunset or the autumn colors, and it's, things are going on in your body, but you can't describe it. Neither can we really describe pain. We're going to talk about some behavioral approaches that you can use to try to make some impact on your pain. We're going to talk about some psychological approaches that are useful, and then we're just going to move on and take questions and look at resources for further learning. Now, it is valuable, I think, to ask the question as they come up. So please don't hesitate to interrupt me. I want this to be as interactive as we can have it. It's so much different when you're doing this live than sitting in my living room. It just feels weird. Okay, so what is pain? The definition of pain is convoluted, but it includes an emotional component. It includes what you think about it. It includes the sensations. There's a lot of things, but one of the ways that you can describe it is a limit has been reached and protection is needed. Now, when they say that, pain tends to be more predictive than it is reactive. Okay, you don't, generally speaking, when you feel some pain, it's trying to keep you from going too far and actually injuring yourself. And when I'm talking about that, I'm really talking about acute pain. And we'll get into the definition of that in a moment. Pain is far more complex than the tissue levels that we tend to think about. And I really can't emphasize this enough. You don't want to fall for the myth that there is a single source of pain. So some of the best pain researchers in the world and educators in the world are Lorimer Moseley and David Butler. And they use this quote: "You will experience pain when credible evidence of danger related to your body is greater than the credible evidence of safety. Equally, you won't have pain when the opposite is true." It's not about the tissue level only. Now, when you look at conceptions of pain, this is a slide that I'm stealing from the Lorimer Moseley and David Butler as adopted by somebody else. And if you look at the blue line on the graph, that would be an intensity of pain when you first injure yourself. And so yesterday I was distracted. I was going down some stairs sideways and I missed the bottom step and I fell down. So right now I got some pain in my elbow right around in this peak area. Over the course of the next couple of days, it's going to calm back down and I will be fine. Not worried about it at all. But if you've got pain that goes up like that and stays up and it moves back and forth, the intensity gets up, then it goes down, then that's when you're talking about an abnormal pain response. It's not the tissue healing. So if it's the blue line, it's going to be more related to the normal tissue healing that you get with any acute injury. But if it stays up and stays high and it fluctuates and it seems to have a mind of its own, that's when we're talking about more of a chronic pain. So story is a big important part of this process. What do you tell yourself? What do you think? What do you believe when you injure yourself? Now, these are models that I think are really interesting. So the one with the triangle here, the gentleman that came up with this is a board certified pain anesthesiologist in the state of Oregon. And as you might be aware, Oregon has had quite a lot of fires lately. And so the fire triangle has been something that he has been, was well familiar with. They talk about fire triangles a lot. And he recognized that the fire triangle was a really good model for pain. When you look at the fire triangle, you know that whenever there's a fire, there's going to be oxygen. You need to have oxygen, you need to have fuel, and you need to have heat. You have to have all three every time there's pain or every time there's fire. But the same is true with pain. If you have pain, you have some sensation coming up from your body. Your peripheral nervous system is picking up information. It's sending it to the spinal cord. It's being blocked or transmitted at that level. It goes up to the brain. Lots of factors are going on to decide the ultimate question, is this dangerous? And if your pain protection system, which I'll come back to in a second, if that pain protection system decides that there's some potential danger, pain will happen. Okay, so it is always going to have a sensation component, but it will always have an emotional component and a cognition component. Now, if we look over on the right side of the screen, there's something here that the people who developed it called a protectometer. And that protectometer is the gauge of how high from the center. Right here in the center would be 0, no pain whatsoever. But you can feel even better than that. You can feel exuberant. You can feel wonderful, right? But if you start here at 0 with no pain, if you have a sense of danger, it's going to go up, 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 up. And it's all related to that sense of danger, whether that sense of danger is because the danger is real to the tissues, or because the sense of danger is not so real to the tissues, but your pain protection system is on overdrive because you are afraid of what's going on. So there's plenty of times that you can have, let's say, for instance, you have a broken bone, a broken leg. The pain, as long as the leg isn't moving, it's not so severe. If, on the other hand, you start to move it, well, that's pretty painful. If you put it in a cast, the pain drops down very quickly, but it is still broken. All right. This is not moving as well as I'd like. There we go. There we go. Now, when we're talking about sensation, when you're talking about pain, the following things are really important. There's localized irritation, let's say at the level of your joints, if you've got some rheumatological condition that such as Richard would be working with. But you also have systemic inflammation that's in the central nervous system. And interestingly enough, the gut microbiome has a whole lot to do with this as well. Now, gut microbiome is a phrase you might not be familiar with, but basically in the central nervous system, there is part of our nervous system deals with the actions that we want to think, that we think about, the voluntary kind of control, but there's also an automatic control. So you do not have the ability to really think much about your digestion, to influence your digestion by how you think, or to influence your heart rate by what you think, or to influence whether you're hot or cold or sweaty. Those kind of automatic functions of our nervous system do have neurological control. So they have, we divide those systems into the voluntary and the automatic, or autonomic is the technical term. And that autonomic controls exciting things to get you ready for a fight or flight, and rest and digest. And the rest and digest actually gets its information from your gut. It's not so much the brain down to the gut, it's from the gut up to the brain. It's quite amazing how that system works. So those are things that are involved in sensation that we need to be aware of. And they were all related to inflammation. So that's part of the what? It's part of the immune system. So if you're talking about pain, you're talking about not only the nervous system, but also the immune system. Now, here's a list of things that you can do that will change inflammation. Knowing what's going on can change inflammation. Getting better sleep will change inflammation. Changing your diet to include more fruits and vegetables, unless you have a vitamin K deficiency, that's a real problem. But there's a lot of things that you can do without cutting out processed foods that will improve your diet and improve your microbiome. Meditation and mindfulness. So that's a picture of where I sit every morning, looking at my candles and doing my prayers and meditations. And movement, particularly movement that you're not afraid of, has a lot to do with inflammation and can calm it down. Now we're going to move on to some specific behavioral choice approaches to trying to help. So this cartoon is pretty clear. Most people tend to like to go for the pills and the surgery, and they don't like to go for the lifestyle changes. But if you have chronic and persisting pain, lifestyle is going to be a big issue. My friend Pete Moore, who we'll talk about later, posted this morning on Facebook, going to the gym today. It's better than taking drugs. He hasn't had any pain medication in, I think he said 27 years, still has pain, but he controls it completely by exercising and pacing and things like that, which we'll talk all about. So the first one is breathing. Remember, I talked a little bit about the automatic nervous system that controls functions such as digestion, controls heart rate, controls breathing, controls all those things. One of the only one of those functions that automatic nervous system controls that you can override is breathing. You can change how you breathe. Now that image that's there is part of the handouts that you have available to you, and we'll talk more about that in a minute. But right now, I hope you can all see me, because I want to do something right now, and I want to use my hand to help you visualize this. So when I inhale, I'm going to inhale through my nose, and my hand is going to go up. And then the exhale is out my mouth. Now, hopefully you noticed a couple of things. One of the things I hope you noticed was that the amount of time I spent inhaling was much, much, much smaller than the amount of time I spent exhaling. And there was a fair amount of time where I wasn't doing either. I wasn't inhaling or exhaling. I was pausing. I get enough oxygen with so inhaling for half a second, exhaling for 10 or 12 seconds, that's not that hard to do. But when you inhale, every time you inhale, your nervous system is gearing up just a little bit for a threat. And every time you exhale, your nervous system is saying, oh, things are okay. So we know this practically every one of us. If we get startled, what will we do? That quick inhalation, that tensing up of all the muscles in your neck and your shoulder and your chest, and you're trying to think, what's going on? What do I have to do? Will I have to fight, or will I have to run, or will I have to protect myself? And conversely, when we are when we realize everything is okay, there's a that sigh, that relaxation response that kicks in. So if you want a practical behavioral approach to calm some of your pain down, best thing you can do is start working on breathing. That is an absolutely critical function. We'll talk more about that in a little bit. Now, this next image is an image that I had an artist do for me. the hose represents stressors, external stressors coming into the container. And the container is your current capacity to deal with stressful events. And then that valve, those are ways you can drain off some of those stressors. I like that image because it gives us 3 different things that you can do to try to build a little more resilience. One is, can you cut down on the external stressors? Sometimes you can, sometimes you can't. Right now, we're living in the midst of COVID, so I'm talking from my living room and you're sitting in your homes listening instead of us meeting in purpose. That's a stressor. We're all feeling that at one level or another. If you have lots of stress, do you have a 1-gallon jar, or a 2-gallon jar, or a 5-gallon jar? If you've improved your capacity to deal with stress, you've got a bigger jar. And then, of course, what do you do on a regular and daily basis when you feel that jar filling up? Can you do something that's going to calm that down? So if you're looking at that, and this is, again, one of the handouts that you have, if you print them out, you can turn this into 3x5 cards. And on the back, there's some ideas, there's some ways for you to document what you're going to do to have some stress reduction activities. So I want you to think about your life and see where you can build greater capacity to deal with the stressors that are available, that are coming to you. Now, the single best predictor of whether or not you're going to develop chronic and persisting pain is if you have crummy sleep. So working to improve your sleep, and this is a bi-directional relationship. That is to say, if you have pain, it's going to be hard to sleep. But if you don't sleep well, you're more likely to develop the pain. If you can improve your sleep, even if you still have pain, your pain will go down. So it becomes a really important target for most people behaviorally to try to do things to help. So developing a routine for sleep is really an important thing. But I guess I should start here with, if you all have smartphones, you can go to the App Store, whether it's Apple App Store or Android App Store, and download CBT-I Coach. CBT-I Coach. And that's an app that you can put on your phone. It gives you instructions and tips and suggestions. It allows you to document what you're doing to try to improve your quality of sleep and your duration of sleep. My girlfriend talked to me this morning about her new watch that she has. She now has, I don't even remember the brand of it. I guess it's a Fitbit brand watch. And it's documenting how she's sleeping. And so she's going to be able to see with some data, not just what she feels like, whether or not she's improving her sleep with the routines. So here's the issue with routine. First is to rise at the same time every morning. Whether you had enough sleep or not, get out of bed at the same time every morning. And the reason for that is because when you get out of bed, you start the clock that will help you be ready for bed that next night. So it might be rough for the first week or two, but it gets easier if you are persistent with that. When should you go to bed? Plan on going to bed 6, 7, or 8 hours before you know you're going to get up. Now I say 6, 7, or 8. We're looking at an ideal of somewhere neighborhood of 7.5 hours of sleep a night. But like many people, I wake up about 3 o'clock every morning. I'm up for half an hour, and then I go back to bed. So I have to account for that extra half hour when I set my go to bed time. If I get into that rhythm and if I get into that routine, I sleep a lot better. I don't have a phone in the room. I don't watch TV in the room. I listen to something that helps me relax as I go to sleep. And that routine has been very helpful in improving my sleep. And if you've got chronic persisting pain, that's what you need to think about. Now, Michael Pollan says, eat food, mostly plants, not too much. That's the best advice I can give anybody on food. But the point is, many of us don't eat enough vegetables. And if you eat too much, a lot of red meat, and if you eat a lot of tomatoes, and if you eat a lot of processed foods, those are inflammatory sorts of foods. Fish, nuts and seeds, if you can tolerate them, have better fats that are not as inflammatory. So that would be the ideal that you'd want to try to have. I don't spend a lot of time on that one, but there are also apps that can help you with that kind of stuff as well. The reason I don't like to spend a lot of time on that is there's a lot of issues related to some people can't tolerate nuts or seeds. Some people can't tolerate more veggies because they have a vitamin K deficiency. So this is one that if you're having issues with diet, I would suggest you go see a dietitian. But know that changing your diet has the potential for changing your pain independent of how much you weigh. But I will say this, you're more likely to have chronic pain if you have too much body fat, because fat actually tends to be a little bit inflammatory as well. Now, building activity tolerance. Again, this is behavioral stuff. You need to move. Your body needs to move. One of the ways you know that you're awake, or I'm sorry, one of the ways you know you're alive is if you move, right? One of the ways that somebody coming up to you just figures out if you're alive is if there's any movement involved. But movement is critical to the body's functioning. And so if you have, it's a way of burning off some of the stress chemicals. It helps you sleep better. If you don't move your body, it's hard to sleep. It improves your digestion, counters diabetes. All those kinds of things are really, really critical. So the question becomes, how can you get started moving if it hurts to move? So we'll talk about that a little bit more in a few minutes. But as a general rule, activity is really critical, and you want to improve your ability to do that activity. Okay, now there are certain psychological approaches. If you are a physician who's working with somebody who's dealing with chronic pain, you may send your client to a counselor who deals with cognitive behavioral therapy or acceptance and commitment therapy. So going to see a counselor can be a really helpful thing. And if you have if you see a physician and they suggest that or recommend that, do your best not to be offended by that. They're not saying it's all in your head, but they are saying that there are tools available in the psychology world that can be helpful at reducing pain. Those people who tend to think it's all in your head, who feel that anyone who says it's other than the body or tissue issues are falling for that myth of a single cause of pain. It's just more complicated. These things will not necessarily get rid of all the pain, but they can be very, very helpful in minimizing it and allowing you to get back to the life that you want to live. Okay, so now, under the psychological approaches, we're going to talk about something called DIMS and SIMS. Now, there is a book out there, which I did not list, called the Pain, what is it called? The Pain Protectometer. Pain Explained Protectometer. I believe that's what it is. Lorimer Mosley and David Butler. Now, they recognize that there are 7 factors that influence your pain. And those 7 factors can be divided into things that are called SIMs, which would be safety in me, or DIMs, that are danger in me. So as a physical therapist, I would frequently find people that would come in every fall for years. They would come in every year, and they'd be in therapy for 2-3 months, and then they'd be okay, and then they'd come back 9 months, 10 months later. Some of them were coming in because they didn't like winter, and that was actually impacting their pain. Some of them were coming in because it was the anniversary of a loved one's death. Now, they didn't recognize that at the time, but that was one of the stress factors. Some of them were coming in because in the fall, several years earlier, they'd had an auto accident. And something about the fall season tended to bring that back, the anxiety about that. Driving into winter is anxiety provoking for some of those folks. So there's a variety of things like that I would see over the years that I would not understand. I did not know how to make sense of that until I started to learn this stuff. But every therapist you ever talk to, if you ask them that question, you will know that they have patients that do that. That is a standard pattern. So here's one. Under the things you see, hear, taste, smell, touch. So the way people who put this together with the book, they will give you a list of, not a list, they give you a pad of Post-it notes. And they want you to actually write down, in this case, looking at an x-ray. Now, looking at that x-ray could potentially make you feel bad, make you feel like, oh, there's surely something going on there. On the other hand, you could look at that same x-ray and in other situations, you might find that makes you feel better because you realize, okay, there's nothing broken. So what it is you're doing is not clearly a danger or a safety. It depends on how you interpret it. It depends on the story you're giving yourself about that. So if you were to look at all the things that you see, smell, taste, touch, the more you look at that, you begin to wonder, is that something that makes me feel good or something that doesn't make me feel good? When I see that fall is coming, does that make me feel good? I love fall. I love winter. One woman that I was working with, we would get her, she was another one of these people that came in every fall, and she was getting so much better. And she came in one day, and I asked her how she was doing, and it was on a Monday. She said, well, not too bad now, but it was terrible over the weekend. I said, well, tell me what happened. She said, well, I was out in the garden trying to clean up the garden. And I felt pretty good while I was doing that. And I was done, but I was just putting things away. And as I was putting things away, the pain hit me, and it was bad. So I asked her to go back and think about what it was that she was doing, tried to describe to me what she was wearing, where she was in the house, or in the yard, what the weather was like. And as soon as I said weather, something clicked for her. She said, that's it. Because she put herself back in that position. And when she said, that's it, I said, what was it? And she said, I got a cool breeze on my neck. And as she told me that, her pain spiked again. So what do you think about winter coming? She said, I hate winter. Now, the beauty of that for her is making that recognition that despite her despising winter and being afraid of winter was a trigger for her pain, was so helpful for her because it started to make some sense that she didn't somehow strain her back while she was doing her gardening. That was her back was where her issue was. And we started to problem solve about what she could do about winter. What was it that she did not like about it? Was it that she was afraid she was going to slip or fall, or was it the cold, or whatever it was? And it turned out it was the cold. And so we made sure that she always wore a scarf, always wore a hat, and it helped a lot. And then she was discharged, and I asked her. I saw her in the health club where we were, she was working out. I said, when's the last time you had any pain? She said, well, 3 days ago, I woke up, I stretched, I felt great. And then I opened the window or the blinds, and it was snowing outside, and my pain came right back. And I asked her what she did at that point. She said, I started doing the breathing exercise we worked on, and everything calmed back down. Sorry about that. I thought I'd turned my phone off. So anyway, this process is a process that you can go through. So if you take this slide and you look at the 7 different categories, you can start to see where you can, people or pets in your life, for instance. One guy I had was just loved his pets, and they were so calming for him, but one of them was older and his favorite one, and was likely to die soon. So his stress went up, his pain went up. But to understand that took some of the fear out of what was happening to him. And he's able to calm that down. He's able to say, okay, what can I do to make me feel better independent of that, so that the weight of things on the sim side is heavier than the weight of things on the dim side, and you will have less pain overall. Anyone have any questions about that? Does that make any sense whatsoever? Okay, that didn't do what I wanted it to do. I'll go back to this current slide. Here we go. That's not what I wanted either. Okay, now, next thing that you can do if you have chronic and persisting pain, this goes back to that resilience bit we talked about before, is to try to become more of a proactive person and just accept what's going on and then move on. Don't spend a lot of time worrying about your pain, arguing about your pain, being mad about your pain. Okay, if it's raining, what can you do in the rain? If you have pain, what can you do to keep moving? Just accept what is and move on, as opposed to constantly obsessing about it. That's a lot easier to say than it is to do. And some people don't talk about it as acceptance, they talk about it as deciding. I decide to continue to have a good life and find ways to have that good life independent of the fact that I have pain. It is certainly possible to do for many, many people. This slide is another one of the handouts that you've got. If you're one of those people who has pain and then it gets better, you think you might be just on that slope right there. And it's just, your plan is, I'm going to do these things and I'm going to get better and better and better and better. But reality is, if you were to zoom out, you'll find that it's more like this. There's your first thing. There should put a little flag right there. But in fact, there's ups and downs, there's changes. Talking about planning for that kind of thing before the setbacks occur has proven to be very, very helpful. And so as a handout, there's a handout that describes how to do that, what to do. And if you print out the page with the cards on it, you can, have front and back of one piece of paper, a little 3x5 card with this kind of a image on it. Patients that I've done this with have been very, very pleased, because when the pain comes back and they have a little flare up or the setback, many times they think they have moved all the way back to the beginning. But in fact, they're progressing down this road, trying to get to where they need to go. The road almost never ends. It doesn't end really until you die. You're going to have issues that you need to plan for, and have a plan what you're going to do when something happens. So on the back side of that card, the first thing that I put down there was, remember that's a setback, not starting over. And second thing is to think about your breathing exercises, because the breathing exercise is your first best control for pain. So on the behavioral side, plan in advance. Now, we're going to talk about exercise right now and pacing. One of the most common problems that people have when they have chronic and persisting pain is what we call the boom bust cycle. You have pain, you don't do very much. The pain fades because you've stopped doing anything, and then you start doing some stuff again, and then the pain comes back. The boom bust cycle means that, to me, that you weren't planning properly. You were trying to be too aggressive too quickly. One of the ways you talk about acute pain is pain comes when you do too much too soon after doing too little for too long. So if you haven't done much for a long time, you've got to be very gradual about how you do your activity. Do a little less at first than you think you can do. Give yourself time to rest and recover before you, and see how you respond to it before you go back. So that becomes a pacing issue as well. So if you're going to, let's say you want to be able to walk a mile for exercise. And you try walking that mile and you find that you hurt for 3 days afterward. Next thing I would say is, well, how long can you walk without paying that price the next day? And you might find 100 yards. Okay. Well, in that case, walk 50 yards, take a break. Walk 50 more, take a break. Walk 50 more, take a break. But you take the break before you start having trouble, as you gradually build your tolerance back up. And that's what it's going to be like whether you're riding a bike or walking or doing some calisthenics or other sort of exercise that you can do in your home. You do some, you keep building up, but you try not to do too much, but you gradually do more and more and more and build that tolerance up. So we're going to talk here about multiple factors that interact that cause pain. Old injuries are going to cause pain, not necessarily because they haven't healed, but because your nervous system remembers that injury was there in much the same way that your immune system remembers that you were sick one time. Your immune system has developed some antibodies for previous illnesses, and your nervous system has developed a sensitivity for old injuries. So even if the tissue is healed, the nervous system is going to be a little more protective of that. And of course, it could be also that it's still weak, never rehabbed all the way. Maybe can't rehab all the way. Lack of sleep, obesity, getting older. You know, you're not going to have the same physical capacities at 80 as you have at 60 as you have at 40. That's just the way things are. Here's an interesting one. Zip code. Okay. People who live in certain zip codes tend to have poorer health behaviors, more chronic pain. Can't fully explain it, but we know that it is true. Can you move out of that zip code and get better? That's perhaps tough. But it has more to do with understanding and what pain means than anything else. Those are all some of the many hundreds of factors that could be involved in pain. The beauty of this image, the reason I like this image, is that some of these things we can't do anything about and some we can. So let's say you have an old injury that never healed fully, that's not ever going to be as strong. what can you do to take some of the load off in other places? Well, you can improve your sleep, you can improve your understanding, you can improve your diet. If you can do those things, then the pain goes away, even if those injuries don't change, even if that doesn't get stronger. But chances are you can get that stronger as well. So this is that card again. So here's another one of the cards that I put up. If you're looking at ways of trying to get your activity level up or to build your resilience, remember back to that 2-gallon jug with a valve in it. Looking at this card, you can try to build into your day some mindfulness and movement snacks, M&M snacks. And what that means to me is, for instance, when I have this habit, this routine that has helped me tremendously by in the morning going into my meditation room and sitting with the candles on. I found when I was able to do that on a consistent basis that I was far less stressed the entire day than if I didn't do that. So that was good, but there were still times that I needed to build in some extra mindfulness, extra relaxation. And so if you're going to have a meal, stop before the meal. You can either say grace or you can quietly just do a minute, 2 minutes of a breathing exercise, and you will feel better. Your digestion will improve and you'll feel more relaxed. As I'm sitting at my computer, every time I stand up, I sit back down and stand back up and sit back down and stand back up. I try to do it 5 times just to build some more activity in. It's not building in an exercise specifically. I'm not going to do a half hour or hour of exercise. I'm just going to do a little extra work here and there as a snack, if you will, a movement snack. So as a behavior, that's something that you can do to start to improve your tolerance to activity. That's much easier than to try to set up to do a specific full exercise program. Now, my friend Bronnie Lennox Thompson, she is a occupational therapist in New Zealand. And in her PhD work, she did a research study, a qualitative research study on those people who actually have pain but are doing well anyway, in spite of the pain. And the question becomes, should decreasing pain intensity be the overarching goal? Now, if you come into a physical therapy clinic where I do work occasionally, the therapist will ask you at the beginning of every session, if pain is one of your concerns, they'll ask you at the beginning of every session how much your pain is, rated on a 0 to 10 scale. And then they are required by hospital policy, this would be Bronson in Kalamazoo, required by hospital policy to ask again at the end of the 45-minute session what your pain intensity is again. Now, that focus on pain intensity all the time is very counterproductive. It assumes somehow that within that 45-minute session, we're going to do something to make your pain get better. It forces the patients to start thinking that, well, this isn't helping if the pain isn't going away. Why are they continuing to ask me if it's not helping? Or it forces the clinician to put you on some passive hot pack or do some massage or something else that doesn't change anything long-term, just so they can change your pain in the short term. But changing pain in the short term should not be the goal. I wish it was, but it isn't. If you've got chronic and persisting pain, the goal should be, how can I improve my life separate from the intensity of pain? So in Bronnie's talk, or in Bronnie's paper, she recognizes that three things that people were able to do to allow them to have a rich and fulfilling life. One was they made sense of their pain. They recognized that their pain was not tissue related exclusively, and that and the important part of that is they were doing themselves no further damage by continuing to move. And why do they want to continue to move? Because life takes place with movement. So they had to make sense of the pain. And the first part of that is to accept that pain is more complicated than tissue damage, and that the pain is not indicating worsening problems. And quite frankly, that's not always the case, but in the vast majority of cases, that is true. So that was making sense. And then they decided that despite the pain, they were going to continue with their life. And then they flexibly persisted. What does that mean? That means that they kept going, but they had to modify things. Some days were worse than others. That means they didn't do as much on those days that were worse. Some days were a little bit better. They could do a little bit more. They modified how they did things to get the job done. To my knowledge, that's the only research study out there to understand how people who live well and still have pain get by. Now, the beauty of this is the first two processes here, the making sense and the deciding, for most people, the pain gets better. The intensity is much less if you do those two things, actually all three of them. But there is no guarantee that the pain will get better. It's not the primary purpose of their life. Look at the PEG scale is something I'm trying to get the Bronson folks to look at, and that's pain intensity, pain, what intensity of pain you've got on the 0 to 10 scale, but also how does that pain impact your enjoyment of life, and how does that pain impact your general activities? 3 different scales that are important. And if you look at it from that perspective, you'll see different answers. The pain intensity might be a 5, but the enjoyment of life is 7. They're still doing good. And their general activities might be a 8. They're able to do everything they want to do, and they're reasonably content. So intensity of pain should not be the primary focus, so long as it is a tolerable level. If it's not a tolerable level, then the thing you do is to go into the breathing exercises is our best bet. Okay, now, to kind of sum things up here a little bit, if you want to take charge of your pain, you should understand that pain is a system itself. It is a protective system. And that system can malfunction. That system can become highly sensitized, and it becomes sensitized most often when you're afraid that what's going on with you is more than it really is. If you've had extra traumas in your life, your system is going to be more sensitive. That's really an important factor to consider. When was your first time you had pain? What does pain mean to you? Okay. Culturally, we see pain as a tissue issue. It's not. It is a system issue. It's a protective system. And anything that we can help ourselves to become, feel safer and feel better protected should impact your pain in a positive way. So I made this slide this morning. This is the only slide on the that's not on your handouts because I didn't create it until this morning because I saw this post on Facebook. Okay. Diet, sleep, exercise, water consumption, all of those factors in life, if you don't assess those and you're just trying to calm things down with medication, then we're in trouble. And by the way, when I was talking about that I want to go back to the slide. And I said something about so long as the pain is tolerable. I'm not suggesting you don't need medication. Sometimes you do need some medication for the pain to be tolerable. That just means that you don't try to have that medication numb it completely. You just get it to a tolerable level, and then you can start going back to working on it. This slide, by the way, this is attempting to show changing from a mechanical sort of thinking about the body as a machine to more of a biological thinking of how systems work in biology. And in fact, we get stronger as you go through stressors. Post-traumatic trauma is real, but post-traumatic growth is equally real. So we want to be able to have both in our lives. So it's a powerful defense mechanism. Pain is multifactorial. And if someone promises to fix you, they're almost certainly lying. They cannot do it. You are not a machine to be fixed. You are a biological system, and you need to put the pieces of the puzzle together. And unfortunately, you are the person that can do that better than anyone else. You can't do it by yourself, otherwise we wouldn't be having these conversations. So you need a team, but that team means that you get people who aren't going to try to fix you, they're going to try to help you fix yourself. One guy that I talked to a lot used to be a driver's ed instructor, and he recognizes that most doctors and most therapists want to be the mechanic trying to fix the body. Well, what he would suggest is that they should be a driver's ed instructor in the car with you as you're making this journey, helping you decide what to look for, when to prepare to make the turn. But you've got to do all the driving. You've got to do all the braking. You've got to do the turning. You've got to use that image of the driver's ed instructor or the coach who's trying to help you. Okay, now, it's pretty much my last slide. At the top, for pain, that's my Facebook pain account, where I share information about research articles. I'm primarily focusing on other clinicians, but if you're on there, you can ask me questions directly, and please feel free to do that. These other ones down here are all resources that are specific to people living in pain, not to clinicians. So the Living Well in Pain, the woman who puts that up, number one, she's outstanding, but she lives quite successfully with sciatica. Chronic Pain Champions is an online support group. And excellent, Tom Bowen is the person who runs that, puts up some excellent bits of information. He tended to use more of that DIMS and SIMS model when he got started. The Pain Toolkit is a series of, it's basically a 12-step program that will take you through step by step of things that you can do to help yourself. He's a gentleman with chronic low back pain. He was a driver's ed instructor. He was a professional interior and exterior home painter. And now he teaches all over Europe. He teaches physicians all over Europe how to deal with pain. Restoring Venus is a friend of mine down in Normal, Illinois. She had 30 years of SI joint pain, pelvic area pain. Now is pain-free. The meaning of pain is, I believe, someone with CRPS, chronic regional pain syndrome. And healthskills.com or WordPress is the occupational therapist I mentioned who has fibromyalgia. So depending on what kind of pain you've got, you can find some specific resources of people who've living with that situation and can help you. And of course, I am very happy to take in questions from you either now or send them through my Facebook page. All right. So that is the presentation.
Yeah, be sure to, if you do have questions, make sure you unmute your mic.
So Don, you were at the previous presentation, but Sarah was not. So I'm going to ask Sarah first. When I asked the question early on, how many of you were at the first presentation I did where I talked more about the meanings of pain? Sarah, did this make any sense to you when I was talking about this now?
Yes, it did.
Okay.
And I have no clue what you covered the first time around, so.
Okay, well, that's all right. So long, I was hoping this would be a standalone kind of a thing. So, my point ultimately is the way we look at pain, the story we tell ourselves about pain is based on a mechanical model that the cultural image is that we are machines and we wear out. That's the cultural image. And unfortunately, it's not true when it comes to pain. The body does change. Obviously, we're all old enough to know that, but those things are not directly related to pain. So if you can continue to have an active and vigorous life in spite of all the stuff that's gone on with you, well, that's what we want to do, I think. Don Triesenberg, were you the Don that said yes, you were at the first one?
No, it's a different Don. It's me, Don Scheel.
Okay, thank you, Don.
Yes, I retired recently. I had been an occupational physician, so a doctor taking care of workers for 30 years. And the triangle that you had early in your talk, the sensation, emotion, cognition, I could see that playing out in my exam room when an injured worker was full of emotion, anger at their boss or how they were treated by the company or how the coworkers treat them or how we treated them, or the anger and fear about their future and their ability to support their families just seemed so evident to me and make so much sense when you look at it as that in that triangle.
So that's why I like that triangle, because it gives a visual that is not as whenever you give a suggestion to somebody who's injured on the job, the thought that it might not be the tissue injury is the problem, they immediately throw up their guard and say, okay, you're just working for the company and you're trying to railroad me back into work or something like that.
Sure. Yep, another emotion. Yep.
Yep. And so that's why I like that triangle. I think that it's really helpful for people to understand and explain, because they can get, most people have heard of the fire triangle when you lay it out that way.
Yeah.
And they can see that, yes, the sensation is there, but these factors are important as well.
Yes, and unfortunately, the worker and myself and others who were involved in treating, and the employers and the human resources departments and the insurance companies, we were all tangled in a knot that made it unlikely that we could embark on a pathway like you are describing.
So when I look at something like that, my first thought is to say, you need allies. Who can be your ally to help you with that? And one of the challenges that I have as a therapist is if I am the only one talking in this language, but the surgeon is saying, well, you need to have this surgery or that surgery because that's the tool that they have, or the insurance company is saying, well, you're faking, you need some sort of consistency in the message for this to work really well. The message that I'm describing is not yet nowhere near fully integrated into the medical system. And so it is a extra challenge to try to bring this up.
Yes, and those injured workers who eventually were lucky enough to fall into the hands of somebody like you and have it somehow get paid for, et cetera. It was so late in the process that I didn't envy the pain practitioner who eventually was able to see them. A lot to undo after months of the,
Yeah, I'm sure we could share lots of horror stories.
yeah, I'm not sure the rest of the audience is that
No.
interested, but I bet you and I are.
So let's move on. Who else has a question and how it might apply, what we talked about might apply to them? Gary?
I have a question.
Yes.
Okay, my question is, how much of this is a learned behavior passed down from family to family in terms of, how your parents acted to pain or didn't act to pain, and therefore what the kids do and how they act to pain, etc.
So I can't answer that question with a number or a percentage, but it is significant. And it's not just learned from the perspective of how your family related to pain. There's a great video that I've seen online with a dad holding on to his child and knocking his hand into the wall hard a couple of times, making a loud noise, and then comforting the child, and the child starting to cry because it began to associate that with, oh, it must have been dangerous because of how dad is acting toward me right now. My daughter fell one time and I didn't react much to her and like her mom would have. And she looked at me in despair and said, "Don't you care?" Because I didn't, immediately run over and kiss her knee or whatever it was. So there's definitely learned behavior. But another one is, it's really fascinating. Some of the research that's coming out now, you may or may not remember that up until about 20 years ago, it was assumed that infants did not feel pain. Boys would be circumcised with no anesthesia, and kids would get their shots. And so a study that came out about a year ago now looked at kids who, let's see if I can describe this properly. The stimulus was a painful needle poke to draw blood, because kids they have some kind of a test on their heel. I can't remember what that is, but my daughter went through them as well. If you put a topical anesthesia on the skin first and then do it, it's much less painful. So they looked at kids and they did it. One group that had no topical anesthesia the first time and then topical anesthesia every time after that, versus the other group that had topical anesthesia every single time, versus the third group that didn't have any of that analgesia. And the pain responses that those kids had, even after they had the topical analgesia, if they didn't have it the first time, they always had an elevated pain response.
Sure.
There was something in their nervous system that was geared toward threat every time they had the procedure, even if there was no actual pain associated with that. But their system was primed already as a result of something that happened as an infant. Now, how that carries on into adulthood is hard to say, but it is a real phenomenon that the nervous system gets primed for threat. And the pain that comes from that, I'm sorry, go ahead.
Is that where the nickname hypochondriac comes from?
I wouldn't go there, but I would tell you that the pain they experience is real. It may not have anything to do with tissue issues. The pain is an experience that is real. And if somebody tells me they have pain, I can believe them. Now, David, he didn't have that luxury. He had some things he had to verify. As a physical therapist, I could just accept it. They had their pain. So, you know, there are some people that will try to game the system, but that is far less common than I think most people expect. And a hypochondriac, I don't know how that fits in.
Pain is what you tell me.
Yep. Thank you, Richard.
Could you put that last chart back up, please, that you did this morning?
Sure.
I thought that was excellent.
The last chart. Let's see if I can find it
Or
here.
graph or whatever that you added this
Yeah.
morning.
Oh, yeah. Got it. I know which one you're referring to now. Should be that one. Is that the one you're
Yes.
talking about?
Yes, thank you. Diet, sleep.
Yeah, and that's the only one that you don't have already. All the
It's
others were.
excellent. Yeah. Exercise. Water consumption. I've never been asked about that.
Yeah, you know, frankly, I've never asked about water consumption with a client either. So, but I shouldn't say that about pain. I have done that often when people have dizziness.
Mhm.
But
That's a great chart. Thank you.
you're welcome.
So that does raise a question about the chronic pain doctors, the people who are Narcan prescribers and all that.
Oh.
That they're using narcotics, which doesn't approach what's causing the pain. It just covers it up for a period of time, and the patient then becomes dependent.
Yeah.
And so I think that any physician who doesn't ask those questions, who doesn't take a look, I feel very sorry for.
Every physician should have that list.
Well, I don't want to be telling physicians how to do their jobs, number one, because the pressures that a physician is under are immense. One of the issues one of the reasons that I started doing what I'm doing is because as a physical therapist, I recognize that at least the strong potential that physical and occupational therapists have a unique ability to help people in pain for three reasons. One is we have a lot more time. Richard and David and any other physicians that might be on this call recognize that it is common for you to have no more than 10 minutes with a patient. And these are difficult conversations to have. And the patient comes to you expecting something right now to help them with their pain. And you want to start talking about getting better sleep. Well, that discussion takes a long time. They don't have the tools to do that. They don't have the time and the ability to do that. So that's where I mentioned to David that you have to have a team. You've got to find clinicians who can help you and extend what you're doing, because it's really the way the medical system is set up. It's really not possible for a physician to deal with this stuff effectively.
I think, Jim, you just touched on there's a team effort that's necessary. This is also one of the reasons, as a physician, I can speak with this, you are often paid by how many people you see. It's like a cattle drive, and you're being paid by non-physicians who are administrators who see nothing but dollar signs. They don't realize that it takes time sometimes to treat people, but they don't allow you that time. And that's why, in some cases, the best physicians who just don't expect to make a lot of money. You just have to take care of people.
Yeah. So really, it's a systemic issue.
Could I ask a very pragmatic, run-of-the-mill sort of question? picking
Please
up
do.
on the role of sleep. What guidelines can you possibly give to someone who's thinking about investigating a new mattress?
Okay, so
I'm not looking for a brand, but I mean, what if
well,
anything?
yeah, the guideline, the only guideline that I feel safe in giving is to do one of those select comfort type things that are inflatable so that you can adjust the pressure to something that you like. That's because it's such a significant investment. If I make a recommendation and you don't like it, then I'm not happy that I sent you a lot of money. So I give you a sort of a one size fit all because you can adjust it yourself. However, generally speaking, personally, I find most people like a firm mattress with a softer top. And last time I was in the market for a mattress, I was up there at, I can't think of the name of the store right now, but it's Jonathan something. It's in the mall on by the Lowe's and the Best Buy in Holland. It's a local manufacturer. I just went in there, lay down, and tried to see what it was like. I have a 3-level fusion in my neck. So I don't have a lot of flexibility. That's as far as I can bring my head to that side. Well, for me, a pillow is the more important issue than the mattress because I can't adapt to a wide range of positions. And so I probably have 8 pillows that I tried before I found one that worked. It is unfortunately trial and error. And some nights one works better than and other nights another one does. And I wish I could change that. Now, mattresses, for me, the neck, if the mattress isn't firm enough, the edge of the mattress stays up while the rest of it sinks down. So immediately I'm in a side bent position. So again, the firmer mattress works for me, but that's just me. I don't know what it works for you. I think a firmer mattress with kind of a pillow top is what I tend to like. So hopefully that will answer those questions. Thank you for that, by the way. So are there any of you on the call that does not have some chronic and persisting pain? All right, Lee, good for you. Don, good for you.
But I think it's been interesting though to have you talk about all this too, because I'm here with my mom who does have some chronic pain, and talking through the kinds of issues about sleep and diet and other things to pay attention to make a huge difference in chronic pain. And she's been with us for a couple of weeks after a fall, and you can certainly see that's been a very different experience than being at her senior residence where everybody's locked in, and you're by yourself and there's no diversion. And it's interesting that the system that patient operates in completely makes a big difference. And this isn't even the medical part, this is just the help with living part, which is a real challenge during the pandemic, that's for sure.
It's a huge challenge. My girlfriend is a social worker, and she does almost all of her visits now over the phone.
Oh.
because she was supposed to do them at people's homes.
Right.
But one of her clients has a terminal cancer, and she has advised him to go out and do things because for him, the risk for COVID is significant if he gets it. On the other hand, the depression and the anxiety of staying at home completely is overwhelming.
Right.
Getting out to do things, having people come over, but be socially distanced while they're over is better for him than to be completely isolated. And it's a case by case thing, depends on how you're coping.
Well, it's interesting that, a lot of the communities that are there to help support, normally like church faith communities or activities, other activities, those are all kind of postponed or, happening virtually, which is not exactly the same thing. So,
Yeah, this is good. I'm enjoying this, but it's nothing like being in the room with you guys.
Right, exactly. No, it's been fascinating. Thank you so much.
You're welcome.
Indeed. Indeed.
So one of the things that I didn't talk enough about, I don't think, was getting started with activity. If any of you who have chronic or persisting pain, but it hurts to start moving, if you have a question about that, I would love to talk a little more about that.
Actually, that would be interesting because, you know, when you're getting through a painful fall or something, you know, nothing's broken. How do you, you know, step in and start doing it again?
So as I mentioned earlier, I fell off of some steps yesterday. Pretty silly thing to do. And my right elbow is painful, but my left side of my low back. And when I first got up, you know, let me rephrase that. A couple hours after I did it, and I'm starting to stiffen up, and I try to stand up, and it's hard to stand up. The first thing I felt was I felt tightness in my chest, and I was holding myself stiff. So I started to do the breathing, and I just consciously relaxed. And then I started walking, but with really small steps. So one of my friends calls it the 1-inch walk. Every step is very short and it's very deliberate. You're working on your balance and you're working to relax into that step. And so the balance challenge might be significant for your mom. So you might want to do that with the kitchen counter right next to her or something else to hold on to. But if she can take a short enough relaxed step, very quickly, my whole body started to relax. And then this morning, my back is fine. But that tension that I felt in my body is like, oh, should I do this? Can I not do this? Was very protective, but it was counterproductive. And that's the thing, that protection is sometimes counterproductive, and you need to decide, you know, you really need to practice to figure out whether it's productive or not.
And you could have gone, thinking back to the triangle again, you could have had a revved up emotional response to that chest discomfort or any other parts of what you were experiencing, and it could have gone poorly.
Oh yeah, it could have. But you know, the biggest part I felt was embarrassment that I did something so stupid. But knowing what I know about pain allowed me to have the confidence. This is the phrase I like people to explore motion with curiosity rather than fear, to see what they can do. Well, what happens if I do it this way or that way? And by far the best tool I've found is the breathing, because you can change your reaction so quickly with the breathing exercise, that relaxed, slow breathing. If you can't, there's probably something more serious going on.
Well, you know, Jim, when you talk about the breathing, the pain is something that's there. You aren't consciously in control of it, but with your breathing, you're consciously controlling your body, and this helps you bring back control and relieve the pain.
Exactly. It is a very practical thing. In the card, I added a little mantra. Breathing in, I calm myself. Breathing out, I smile. That's actually something I learned from a Buddhist teacher one time. And so saying the words sometimes is as powerful as the actual mechanics of breathing. But it just takes some of that control, brings it to a level that you can work with, and then begin to explore. Is it feasible? Am I really safe? And it turns out almost always I am. And if I'm safe, then the pain goes down.
One area that we really haven't talked about is referred pain. Why do people with heart attacks have pain in their right arm? Why do people with gallbladder disease have pain in their back? Those are acute pain, so it's really not chronic, but it is a very interesting phenomenon.
Well, it's a fascinating phenomenon, as is phantom pain. And if you don't know what phantom pain is, that would be feeling pain in a body part that has been amputated. So if you've lost your arm, you can still have pain in that arm, even though it does not exist. So the answer to the question that Richard asked about referred pain from a somatic purpose, that has to do with, let me rephrase that. My understanding of that is not completely up to date because I've been focusing on chronic pain. But my understanding is that that all relates to fetal development and what tissues come from what initial cells.
That's correct. I mean, it was an ectoderm, mesoderm, endoderm.
Yep.
But either way, it can be very confusing.
Yes, it can. And I don't want to minimize the threat that pain poses, in the sense that pain is a very important part of everyone's protection system. It's self-protection. The question is, what is it protecting you from? Is it truly something you need to pay attention to, or is it something that our previous experiences as kids or our previous history with trauma has got our system ramped up much higher than it needs to be for that particular issue? And if it's ramped up higher, then the protection system is not giving you accurate information about the health and status of the tissues. But
it's all of that, Jim.
Yeah, but the health and status of the tissues is what we normally assume pain means. And so we have to break that assumption and start looking at things in a little bit more detail.
That's the idea of tissue level pain and not
Exactly.
system level pain.
Yes. Exactly.
Are there any other questions from the audience? This is now 2:30. Have all the questions been answered that people have to Jim? We'll all speak at the same time. And I want to thank Mr. Stark for his time. Jim is one of those few people that I've dealt with who really understands chronic pain. And it can be very frustrating as a physician to have that kind of understanding and try to treat people. But when you do succeed, it really is very gratifying. Jim, thank you for your time. Thank you for all of you coming today. I hope you've learned something from Jim. And again, we invited him back this time. If you have more questions, let me know and we can invite him back again.
Okay.
If he'll come.
One last thing here. Lee just asked if I mentioned the slides would be available. How can I get them? I sent them through a couple days ago, and so they should be up on the HASP. I'm not sure exactly how HASP sends those out, but somebody else had asked if I can send that extra slide that I added this morning, and so I will send that through to. I can't even remember the woman's name that I sent it to.
You sent it. I think you originally sent it to Kim.
Okay.
So you can just use that email address, or send it to me, timmer@hope.edu, TIMMER. I'll catch up with you afterwards, but I can forward that new presentation with that extra slide to everybody in attendance.
All right, very good.
And we very much appreciate you making that available. I'm going to go ahead and stop the recording.